Dr. Nadir. Um, I'll be your moderator for today. The red team will be presenting today. So at the beginning, this is the agenda for today's meeting. At the beginning, we have Dr. Leina and Dr. Duaa. They're going to be talking about pulmonary disease in older adults. And then after that, I'm going to be talking about the ranking list. And then we're going to have a discussion with Dr. Abubaker. And then after that, we have Dr. Razan. She's going to be talking about apps and applications that are used by interns during the first year of residency. And then after that, we do have Dr. Rawan. She's going to be talking about Google Scholar for academic research. And then we're going to have an input from one of the previous fellows, Dr. Wael Safi. And then we're going to end up with project updates. So I hope everyone enjoys today's presentation. And I'll leave the floor for Dr. Duaa and Leina to start.
Just 1 second while I figure out how to share my screen. Okay, screen. Does anyone know what's the problem? I'm trying to. Oh.
I can share my screen. I can open the slides from my screen.
Can you see it now?
Yes, we can see it.
So hello everyone, I'm Leina Elomeiri on behalf of the Red Team. Today I will be presenting respiratory diseases and disorders among geriatric population. So our objectives today are how to evaluate common respiratory presentations in elderly, such as dyspnea, chronic cough and wheezing, the 5 A's of helping patients to quit smoking, how to recognize and treat major pulmonary diseases in elder population, decision-making about mechanical ventilation at the end of life. We will cover age-related pulmonary alterations, common respiratory complaints and symptoms, major pulmonary diseases, and intensive care of critically ill patients of elder population. As we all know that the age-related pulmonary alterations appear at the reduced airway size, shallow alveolar sacs, reduced chest wall compliance, intercostal muscles become atrophied, and there is a reduction in the diaphragmatic strength by 25%. So in elder population, there is usually a difficulty in recognizing respiratory symptoms. A common misconception is that the older people tend to overestimate or exaggerate respiratory symptoms. The opposite is often true. Older people often have more than one explanation of their problem. Dyspnea, cough, and wheezing may overlap. The cause may include a combination of disease such as asthma, emphysema, COPD, obstructive sleep apnea, heart failure, and GERD. Our first topic of today is rhinosinusitis. Approach to the diagnosis and treatment are the same regardless of any age population. It can be acute, subacute, or chronic. Usually, we treat bacterial rhinosinusitis with analgesia, saline irrigation, and antibiotics if the symptoms exceed the 7-day period. But we withhold antibiotic in mild disease as it can be more harmful than useful. Chronic rhinosinusitis is treated with topical agents and saline irrigation. On the other hand, allergic rhinosinusitis is treated by avoidance of the precipitating factor and topical nasal steroids. The second symptoms of our population today is dyspnea. It's common to be considered in COPD patient, cardiac disease, asthma, interstitial lung disease, and deconditioning. It doesn't usually correlate with the oxygenation or pulmonary function test of the patient. However, history and presenting complaints help you to tailor the testing and empirical treatment of choice. The language that the patient usually uses describe the dyspnea and help to tailor your diagnosis toward one end. Heavy may imply cardiac dysfunction, and tight may imply angina or asthma. The third one is chronic cough. It's usually of a benign cause in elder population. The most common is postnasal drip, asthma, and GERD. A reasonable approach to the treatment is empiric treatment for those conditions. A combination of these conditions may occur together, so treating multiple causes may warrant when signal therapies are ineffective. We also have wheezing, which common causes include asthma and postnasal drip. Pulmonary edema is associated with heart failure and may present as cardiac asthma. Airway hyperresponsiveness from chronic bronchitis is not uncommon in older population with a history of wheezing and sputum and tobacco use. As we come for the major pulmonary disease in older population, we find that there's asthma, chronic obstructive pulmonary disease, obstructive sleep apnea, idiopathic pulmonary fibrosis, pulmonary thromboembolism, pneumonia, and lung cancer. Start with asthma. It is estimated that 5 to 10% of people older than 65 years old meet the criteria for obstruction and bronchial hyperactivity. Asthma is under-recognized and under-treated in older population. 50 of all asthma deaths are in the people above 65 years old. When we come to the treatment of asthma, inhaled corticosteroids and other controller drugs such as leukotriene receptor antagonists are the mainstay of the therapy. Use the lowest effective dose. Beta agonists should be used as needed as a reliever medication. Instruct in the proper use of BEF monitoring because of the older person decreased perceptions of bronchoconstrictions. We find that the commonly used inhaled medications are the beta agonists, those ending with trolls. We have albuterol, vivitrol, formoterol, salmeterol, with their trade names. The second class of drugs is corticosteroids. The third class of drugs could be a combination of inhaled corticosteroids and long-acting beta agonists. And we have the final class, which include other types of drugs, including ipratropium, albuterol-ipratropium combination. All of them can be used at the management of asthma in elder population. We go on for our second disease for today, which is COPD. It is estimated that 15 million people in the US have COPD. It's the fourth most common cause of death after heart disease, cancer, and stroke. Its prevalence and mortality are increasing, especially in elder population. Morbidity and mortality from COPD accounts for more than 15 billion per year in US medical care expenditure, mainly due to hospitalization. As we come for the diagnosis, wheezing is the best predictor of airflow limitation. Patients with COPD are 36 times more likely to have wheezing than other populations without the problem. We have other predictors for COPD, such as parallel chest, shaped chest, hyperresonance on percussion, and forced expiratory time more than 9 seconds measured during the clinical examination. So the key guidelines for the diagnosis of COPD is dyspnea, whether it's progressive or worsening over time, worse with exercise, persistent, described as increased effort to breathe, heaviness, air hunger, or gasping. Chronic cough must be there. It can be intermittent or non-productive. Sputum production, any pattern of chronic sputum production can indicate COPD. And we should have risk factors such as tobacco smoking, occupational dust and chemicals, smoke from home cooking and heating fuel. Second, we come for the spirometric classification of COPD. So we have, we can classify to mild, moderate, severe, and very severe, depending on the forced expiratory volume, first minute. More than 80% predicted is mild, less than 80% predicted, but more than 50 is moderate, less than 50, but more than 30 is severe. Less than 30 predicted or less than 50 predicted and chronic respiratory failure is very severe. So smoking cessation slows the decline in lung function at any age. We have something called the 5 A's to quit smoking or help the patients to quit smoking. The first A is ask the patient about use of tobacco at every office visit. The second A is assess readiness to quit. Ask him a question, is he willing to quit or not? Did he take any measurements to quit before or not? The third is advise patient to quit. You have to repeat this every time he comes to the office. The fourth one is assist patient in the quit attempt with aids such as local cessation programs and pharmacological agents such as buprenorphine and nicotine replacement. The last A is arrange both quit date and follow-up visit or contact to discuss the quit attempt. So ask the patient each and every visit, is he smoking? Is he still smoking or not? Assess if he's ready to smoke, to quit smoking. Advise him on the harm of smoking and that he should quit. Assist him with any means that could help him to quit smoking. And arrange a date with him and keep asking him about it each and every visit. COPD therapy or management. So as for mild cases of COPD, we use short-acting beta agonist, SAPA, when needed. Moderate COPD, regular treatments with one or more bronchodilators, or use long-acting bronchodilator if needed for added benefit or if more than 2 exacerbations per year. And rehabilitation. For severe COPD, regular treatment with one or more bronchodilators as above. We can introduce inhaled steroids or if insignificant symptoms and lung function response, or if there is more than 2 exacerbations per year. And we continue with rehabilitation. Very severe COPD, we use also the regular treatment of 1 or 2 bronchodilators, inhaled steroids, and treatment of complications. We can introduce long-acting oxygen therapy if there is respiratory failure. We have other interventions for COPD other than the mentioned above, such as oxygen therapy, exercise training, respiratory therapy and education, treatment of major depression and anxiety, as it presents in more than 40% of COPD patients. Anxiety may lead the patients to seek help in the ER or be admitted to the hospital regularly. We move to our next topic of today is obstructive sleep apnea. It warrants a high index of suspicion. It's life-threatening, usually potentially correctable, associated with stroke, myocardial infarction, and it causes a threefold increase in mortality. It's often underdiagnosed and therefore untreated. We have several options for the treatment of obstructive sleep apnea, such as, and we start with weight loss, avoidance of alcohol and sedatives, sleep on one side or upright, correction of metabolic disorders such as hypothyroidism, and the use of CPAP, continuous positive airway pressure via nasal mask. So I will stop here and hand the presentation for Duaa. She's
Thank you so
online.
much, Dr. Leina. Can you hear me?
Yes, I can hear you.
Okay.
Do you want me to continue
No, I'll
screening?
share my screen. Thank you.
Okay.
Can everyone see my screen?
Yes, we can see your screen.
Okay. I'll start by presenting about idiopathic pulmonary fibrosis, which is a very relentlessly progressive disease, and it has a median survival of 3 to 5 years. The patient usually presents with insidious dyspnea and cough. As we know that idiopathic pulmonary fibrosis also present with clubbing, and that is present in more than 40% of pulmonary fibrosis patients. And it's usually not present in emphysema patients. Commonly, idiopathic pulmonary fibrosis is treated with oral corticosteroids, but only 10 to 20% of patients respond to this treatment. And usually we have the adverse effects of corticosteroids are more prominent than the response. Early referral to a subspecialist is warranted if the patient wishes to consider further therapy as lung transplant, for example. Going to a very important topic, which is pulmonary embolism, and its incidence triples from age 65 to age 90 years. In patients of 70 years or old, they are at risk for misdiagnosis. Usually, we do blood gases, but it's normal in 10 to 20% of patients, and in other patients, it presents with hypoxemia and respiratory alkalosis. The diagnostic workup for pulmonary embolism is same as in younger patients, and that depends, of course, on the DVT, if it's explained or unexplained. For example, if it's unexplained DVT, we do more workup, but if it's explained, like the patient has cancer, for example, or they just came back from a long trip, we give them anticoagulants from 3 to 6 months. And we have a 10% recurrence rate within the first year. And in these cases, the anticoagulation will be for life. Anticoagulation is guided by the same principles as in younger adults. In older patients, it may be even more important to achieve therapeutic levels of heparinization quickly. And the use of outpatient low molecular weight heparin while achieving anticoagulation with warfarin is supported by well-designed trials. So we start both of them at the same time, and we stop the low molecular weight heparin after 3 days till we get the warfarin in the IR target of 2 to 3. In most cases, anticoagulation therapy should continue for at least 6 months, and that's just for the first time of diagnosis pulmonary embolism. But if the patient came back with a recurrent pulmonary embolism, then we give them the anticoagulation for life. Moving to intensive care of the critically ill patients, we have the support trial, which was done to improve the quality of life for patients, and it showed that physician error rates in approximating patient preference for mechanical ventilation was 36% for patients less than 50 years and 79% for patients more than 80 years. And the cause of that was suggested by the support study is its low patient physician communication. Physicians should be more consistent in attempts to elicit patients' preference for DNR orders. So that's what we need to focus on, that what the patient wants, the patient and their family, what they want, more than what's the likely outcome of mechanical ventilation. Can you please mute? So the decision to use mechanical ventilation should not be based on age alone. It should be based on other factors that we'll talk about in a bit. Unlike the general medical ICU population, patients with acute lung injury and ARDS appear to have higher mortality with advancing age. Acute lung injury patients require nearly twice as long to be liberated from the ventilator. And usually the cause of their death is the comorbidities of these patients. Also, cognitive decline often dramatically worsens after an ICU stay and becomes a major threat to quality of life. So this is a study that shows a study of 851 patients that shows the outcome of mechanical ventilation. 63% of patients were successfully liberated from mechanical ventilation. 20% were drawn from the ventilation due to many reasons, and 17% of patients died while receiving mechanical ventilation. The American Medical Association recommends a standardized, fair process rather than a strict definition of futility. And medical futility is medical futility means the proposed therapy should not be performed because available data show that it will not improve the patient's medical condition. So here we need to focus more on the fair process rather than the strict definition of futility. And also we need to focus on these three factors more than the chronological age of the patient. And these factors are the clinical efficacy of treatment, the likelihood of mortality, and the subsequent quality of life. In summary of this presentation, with age, the FEV1 and the PaO2, while the AA gradient increases. 5 to 10% of people with of age 65 or more meet the criteria for asthma. Smoking cessation may allow the decline in lung function at any age, and that's why we need to keep talking to the patient about smoking cessation. Most patients with COPD derive little or no benefit from routine inhaled corticosteroids, but a brief course of systemic corticosteroids may reduce the duration of an acute exacerbation. Older people recover pulmonary physiology at the same rate as younger cohorts, but in some disease states they may require a longer time to be liberated from the ventilator. We're going to come to the cases. We have 3 cases. The first one, a 72-year-old man comes to the office for evaluation of dyspnea that has progressed slowly over 6 years. He has COPD and has used albuterol as needed for 6 years. He has a daily non-productive cough and wheezes intermittently. He can no longer participate in activities such as golf. 6 months ago, he had an exacerbation of COPD requiring prednisone. He has never been hospitalized or gone to the emergency room, and he quit smoking 3 months ago. On exam, his temperature is 36, his blood pressure is 145/85, heart rate is 96 beats per minute, and respiratory rate is 22 breaths per minute. He doesn't have any accessory muscle use, bibasilar crackles are audible, and exhalation is slightly prolonged. Cardiac exam is normal. There is trace ankle edema, but no cyanosis or clubbing. Oxygen saturation on room air is 93%, and his chest radiograph displays hyperinflated lungs. His PFT shows a forced vital capacity of 85% of predicted, FEV1 of 60% of predicted, and his FEV1 FVC ratio is 60%. After treatment with a bronchodilator, FEV1 increases by 11%, and his FVC increases by 10%. So in this patient, in addition to continuing albuterol as needed, which of the following is the most appropriate treatment at this time? Put your answers in the chat. Any suggestions? We have B. We have E. We have B. So the answer is D, tiotropium. And the reason for that, what do you guys think that this patient's COPD severity rate is? Does he have severe COPD or moderate or mild COPD? So this patient has a moderate COPD, and in moderate COPD, we give usually more than one bronchodilator. He's already taking albuterol, and the second one would be tiotropium. And the reason for that is it improves the lung function and improves FEV1. And that is not just compared to albuterol, it's also compared to ipratropium. So tiotropium showed increase in the lung function and also decreases the exacerbations of COPD. The second case of a 75-year-old man evaluated because he has sudden onset of shortness of breath, sharp pleuritic left-sided chest pain, and cough productive of blood-tinged sputum. He had elective hip replacement surgery 6 days ago. He has been and is wearing pneumatic compression devices on both legs. He has a 20-year history of COPD. He's taking a proton pump inhibitor for duodenal ulcer, diagnosed 2 weeks ago, and albuterol as needed. His temperature is 38, his blood pressure is 165/90, and his heart rate is 110, his respiratory rate is 26. There is no accessory muscle use. The patient has slightly expiratory wheezing. There is no jugular venous distension. A left-sided S4 gallop is audible. The abdomen is soft without masses or hepatosplenomegaly. There is no cyanosis, clubbing, edema, or thigh or calf pain. His white blood count was 13,000 with 85% of polymorphic nuclear cells and 6% bands. His D-dimer was less than 500, and his ABG on room air showed a pH of 7.48, a PaO2 of 70, and PaCO2 of 30. An ECG reveals sinus tachycardia. His chest radiograph reveals left lower lobe atelectasis or infiltrate. His VQ scan indicates a low probability for PE. Bilateral lower extremity Doppler ultrasonography demonstrates no evidence of DVT. So which of the following is the most appropriate next step? Do we treat him with heparin, place an inferior vena cava filter, treat with antibiotics and steroids, we obtain CT of the chest, or obtain CT angiography of the chest? Any answers? We have D, C, E, C, C. The correct answer is E. Yes, which is obtain CT angiography of the chest. And this is a case of PE, and although this is tricky that the VQ scan indicates a low probability of PE, and his Doppler showed no evidence of DVT, but the symptoms of this patient suggest pulmonary embolism. And if you notice that his pH shows mild respiratory alkalosis and hypoxemia, and the gold standard for PE is CT angiography. So we need to obtain that to make sure that it's PE or not a PE. The last case would be a 70-year-old retired mailman comes to the office because he now has difficulty climbing one flight of stairs. He has dyspnea on exertion that has progressed slowly over 5 years. He wheezes occasionally. He has had a minimally productive morning cough for many years, but no chest pain or discomfort. He has a 50-pack year cigarette smoking history and still smokes. His temperature is 36. His blood pressure is 115/75. Heart rate is 98 beats per minute, and respiratory rate is 22. He doesn't have accessory muscle use. He has bibasilar crackles that are audible. His cardiac and abdominal examination are normal. There is trace peripheral edema and mild clubbing but no cyanosis. His chest radiograph is normal. His PFTs shows a forced vital capacity of 65 of predicted, and FEV1 of 70% of predicted, and his FEV1 over FVC ratio is 75%. After bronchodilation, his FEV1 increases by 9% and his FVC increases by 8%. So which of the following is the most likely cause of this patient's dyspnea? Is it asthma? Is it COPD, idiopathic pulmonary fibrosis, pleural effusion, or pulmonary embolism? We have C, C, yes, that's correct. The answer is C. And this will be our presentation for today. Thank you very much. If you have any questions, please go ahead.
Thank you, Dr. Leina and Dr. Duaa. If anyone has a question for them, you can ask before we go to our next agenda.
Thank you both, Dr. Duaa and Leina. Excellent presentation. So it's an important topic, and you're gonna see a lot of patients with COPD or asthma, as we get older, as they mentioned, it could be combination of more than one disease when they come to you with shortness of breath or so. So just take a moment and review these important topics so that you can help your patients in the future. Thank you.
Thank you, Dr. If there is anyone who has a question?
Yes, I can see 2 questions in the chat. So the first question is, why not ipratropium for Q1? I actually reviewed this area earlier, and I found a study that shows that compared tiotropium to ipratropium. And as we both know that these are anticholinergic bronchodilators, the tiotropium has a longer, it's a long acting, and they compared both of them, and it shows that tiotropium reduces the lung hyperinflation, and it also improves the patient's exercise capacity. It also decreases the COPD exacerbation rate, unlike the ipratropium. So this is the answer for this. In PE, we calculate the Wells score. Yes, I think we do. If Dr. Nader can also give an input for that. We also have another score that's also called the BOVA score. You can also read about this one. Any other questions?
Thank you, Dr. Duaa. If no one has any additional question, we're going to go to the second agenda,
I'm
which
going to
is
just comment on the Wells score. So to do that, I'm going to share with you the calculator here. So you can use any free calculator. This is one online MedCalc. So you go over all these questions and answer, and then you're going to get the score. So it's specifically for PE, as mentioned. If you want to read more about it, you can get more information about the author or how did they study. So they have more information in the website. So go to MedCalc and then you can review that. Thank you.
Thank you, Dr. Nader. So we're going to go to our second agenda. I'm going to share my screen. Okay. Can you see my screen?
Yes.
All right. So yeah. So our second agenda is the NRMB ranking. As as the rank order list deadline is already approaching, and as most of us now are creating their rank list. So this is kind of important for those who are applying this year and those who are planning to apply the coming season. So the agenda for today's presentation is that what's to consider when it comes to, before creating the rank list and then creating the rank list. I'm sorry. I'm just going to move. I'm sorry. I'm in the study area, so I'm just going to move because it's kind of... Give me 1 minute. So I'm back. So I'm sorry for the inconvenience. So the agenda is that we're going to talk about what are the factors that we need to consider before creating the rank list and then creating the rank list itself. So before creating the rank list, it's very important to look at the program type. And this is usually dependent on an individual's future goals, whether you as a resident, you want to, after residency, you want to continue in primary care versus if you want to go for fellowships in, academics, being a scientist also. So this depends on the choice of going either to a community program or an academic program. And even in the academic program, whether wants to go to a university program or a hospital affiliated or university affiliated program. And the other factor is that the training itself, we do have a lot of options, and we usually want to look at if the program is well-rounded when it comes to the different subspecialties. Is there is a protected didactic times and rounds times? If there is a simulation labs, is there is a community outreach opportunities, and if there is a teaching opportunities, and those are kind of important when we want to go to a competitive fellowship. And does the program has an emphasis on the desired fellowship? For example, I want to go to vascular neurology. So how much of an amount does the program has? I mean, how much of an exposure does the program has an in-house fellowship, desired fellowship? And then we do have the working hours. How much of an inpatient and outpatient exposure do we get in the certain program? And then also the number of training facilities and how far they are from each other's. Other factors are the board passing rate, and other factors are the program support. When it comes to financial supports, certain programs, they do have financial support to buy, learning tools, question banks, books, study materials, the step 3 exam. Certain programs pay for the step 3 exam, and also the travel allowance for different conferences. And the last thing when it comes to the training is the personal development activities. Certain programs, they do have leadership activities and soft skills activities. The second thing is the program environment. One of the very important things to consider when ranking the program is the program leadership. How invested is the program director and the chief of the program when it comes to the development of residents, the residents' well-beings, the amount of support do we have during the training versus autonomy, because we want a place that allow us to work on our own, but at the same time we feel like someone got our back. If we want to ask about something when it comes to patient care, we can approach them in approachable seniors. Also, evaluations and feedback, if there is an standardized evaluation and feedbacks from seniors, and the mentorship. And mentorship is specifically is important when it comes to the desired fellowship. For example, I want vascular neurology, so there is a mentor when it comes to vascular neurology. Also, the wellness activities within the program, and overall, how are residents satisfied? And this is something we can all see during the meet and greet, and also during our interaction with the residents and with the program. And the last important thing within the environment is the patient's population. So the type of patients we see, the language they speak, the culture the patients have. So another thing is also research. For those who are interested in research, does the program has research center? What are the opportunities that are available for the residents? Is there is emphasis on the desired fellowship when it comes to the research, for example? Does the program has NIH grants, and also if there is clinical trials available, and would residents be able to be involved in them? Another factor is the city or the area where the program is located. It also depends on a personal preference. Some people prefer the urban setting, and others prefer the suburban setting. And the living expenses, there is one of the things that I came across is the living calculator, which is, it's like you do enter the city that you're the program is staying in, and then it's gonna give you the total amount that you need, and then you can compare it to the salary. And also it can show you the amount of groceries, how much the groceries, the rents, and everything. So it's also important to consider like the rent rates and the apartments, how proximal they are from the from the hospital. If there is available grocery stores, including halal markets, for example, if there is a gym or hiking and running trails, the safety of the area, the support system when it comes to family or relatives or friends or even acquaintances within the area. And for those who have kids, the schools and the daycare availability within the program and or around the area of the program. And the last thing is the salary and the financial reimbursement, compared to the living expenses. So the salary amount, the taxes within the specific city, because certain states, they do have higher taxes amount, paid leaves, parking, is it free or you have to pay for it, if there is a food allowance and others. So one of the tools that we can know about all this information is generally the impression we get from the interviews and while interacting with residents and residents' feedback. Another tool is Residency Explorer. Another one is Reddit. There are a lot of IMGs who post about programs. And then there is Doximity. So I came across Doximity. Let me share with you guys. I came across something in Doximity that was very interesting for me. Okay, there is so there is the residency navigator in Doximity that you can sort by the different specialty. So for example, like here you can choose the specialty. If you want internal medicine, let's for example choose neurology. And then you can rank the programs by the reputations. For example, it's going to give you the programs here. And then after that, if you want by research output, also it can show you the programs sequence or the rank, and then also the size of the programs, the percent of subspecialized alumni, and different. We can enter different filters. So also you can choose, is it all US or Northeast or South or Midwest or West. And then also if you want large hospitals or VA or pediatrics, and then also the training environment, is it urban or rural? And then after that, the intended fellowship, for example, let's choose vascular neurology. It's going to show you the programs that they have good vascular neurology, or for example, good research output. So this is also a really good tool, to while preparing the list. So let's go to creating the list itself. We do have the NRMB website. Let me open the NRMB website. Yeah, so after opening the NRMB website, like this is the home, then you go to ROL, which is rank order list. And then you go for the search bar here, like find and add programs. And then based on the interviews you got, and based on the states in which you got the program is located in, let's go, for example, to Arkansas. And then you can look at the specialty, for example, neurology. Okay. And then after that, you can go for search. And then you get, this is University of Arkansas at Little Rock. Then you can select if this is the program that you interviewed at, and then you can add. And then you get this, you get this as, for example, if you want to put it as number one, then this is your number one. And then you can also change the orders from here. And always try to check for the NRMB code, because certain programs, if this is a categorical, for example, we can also check it over here. So this is categorical. So certain programs, they do have, like within the same program, categorical, and then they do have also prelim. So you can check over here. And then after that, you can also double check with the NRMB code within the program, like with the program that you got the interview from. Also, there is what's known as the supplementary era. So let's try that. Let's try, for example, Pennsylvania, and then let's go to neurology, for example, and then you can add, okay, let's search. Okay, I'm sorry. So let's go to Pennsylvania. Let's do neurology. And then we can search, and then it's going to give you all the institutes over here. So for example, Albert Einstein, let's do Albert Einstein. So this is an advanced program. So let's add the program, and then usually advanced program over here, you're gonna find a bar in which you can add the supplementary. For example, for the prelim, certain advanced program, they require that you add a supplementary. So you're gonna come here and search, do the same search thing. Let's do Pennsylvania. Okay, and then the specialty, neurology. So okay, yes, okay. So it's a prelim. Okay. You can also enter the other, bars, like for example. But for example, here we entered like Pennsylvania, prelim, neurology, and then we can search. There are no programs found to the search criteria. Okay. Okay, my bad. Okay, we can also enter it, like for example, Albert. I don't know why, but let's. Oh, it's in. So the prelim is usually, like, my bad. The prelim is usually considered as internal medicine. So when we enter the, because the code is different. So like now, okay. Okay. Let's try internal medicine, then search. So you see, like when we entered internal medicine, because the prelim is kind of considered as part of the internal medicine, even if it's neurology. But here inside, we can see that this is medicine prelim, neurology, and then medicine prelim PM. So we're going to choose this, and then we're going to add it. So it's going to be added as a supplementary. So when we're going to go to the primary rank order list, we can see that it has been already added as supplementary rank order list. So this is pretty much like it. If anyone has a question, I can answer it. I can see that also now we do have Dr. Abubaker. He's going to be giving us his input when it comes to the rank order list, and he's also going to answer your questions. The floor is yours, Dr. Abubaker. I think you're muted.
Okay, sorry. Assalamu alaikum, everyone. First, congratulations, you made it this far. Inshallah, you get, all of you get what you're looking for, and you match in your first, basically, rank program. Honestly, I'm more open to questions rather than like I have anything. I think you already went over the process, how to rank, and like the process of ranking and certifying basically your list. The next is mostly questions. Rufida, you lead.
Yes.
Okay.
Thank you, Dr. Abubaker, for being here. I would want to ask about, like, for example, if I want a program that it's invested in academic, and at the same time they do have an in-house fellowship. Does it matter if it's a hospital affiliated and if I have other options of university programs, but they do not have the same, for example, properties? So do you think it does make a difference if it's just a hospital affiliated while it's not university programs? Should I rank it as my number one?
I mean, it's a good question. So, I mean, generally for a university program, usually it helps you matching in like a different program if you're applying to a different hospital. But if you know that, for example, you're applying for cardiology or GI, and that program has a decent program in GI or cardiology, I think your chances are way higher actually in your program. So if it works with you, maybe it's better. When it comes to ranking, I mean, I missed part of the your presentation. Maybe I came in the last very few minutes. But I mean, ranking, like if me and you had the same interviews, I think my ranking would definitely be different than yours, depending on my priority. Some people have the priority for the geographical area where they have like families, they have support, they have like whatever, or like their spouses are around that region. Some people prefer, if they are invested in a very competitive, for example, fellowship, then your priority becomes a program that helps you get into that fellowship. So, I mean, not necessarily we have to agree on like 1, 2, 3, 4, and 5. Some things that I want everyone to keep in mind too is if you go to a program that has support, someone you know in the program, like a senior, a friend, and or like a colleague from your school or someone you know, it will be much easier because they will give you an insight in the program of what to do, what to avoid, how to impress like certain physicians, what to do for each rotation, what to expect for each rotation, and how to prepare for it. That will give you like a head start and will make you like start with the right foot from the beginning. So, I mean, with all that being said, going back to your question is generally, if I were you, and I know I'm applying for a competitive fellowship, I would want to have it in-house, being very honest. If that answers your question.
Yes, it does. Thank you very much.
Thank you so much, Dr. Abubaker, and thanks for the question. I'd like just to add one more thing. I think at this level, if you have more than like dozen or some interviews and you are 100% sure they will accept you, your chances, then I will definitely go by selecting according to the next step, the fellowship. But at this level, I think we should focus on which one of the programs you want to get in, and that will support you at the PGY 1, 2, and so forth. If you are looking for the fellowship and you want to go to a competitive fellowship, although you are interested in a program that is not competitive as far as fellowship, or they don't have that fellowship, I think you should rank that first, and when you get in, you can select an elective, and Dr. Abubaker, maybe you can help elaborate on that. In a program that's competitive, let's say you get into a smaller program, academic program, but they don't have the competitive fellowship, and you are interested in that competitive fellowship in a different program. So you go in, you put your foot in the system, and you select, usually the second year, or you can do it first year, an elective where you go to a bigger program, well known in the area that you are interested in. And if you do some research work, or some activities with well-known physicians there, then if you publish, you will be more competitive when you apply to the competitive programs. So there is a loop, or there is another way to get to your destination. The easiest one, what Dr. Abubaker mentioned, is if you have the program and you are interested in fellowship in that program and it is competitive, but this doesn't limit you from going to a different lower program with the same intention to reach that goal. And there is a way to do that with external rotation. And if you think about that, think ahead of what programs you want to do your rotation. When they accept you in the first program, you still have 3 months to start. So you have to do your homework to look at which, if you're interested in cardiology or hematology or GI, then you want to look at this external rotation. So you will do maybe one of these rotations. You can elaborate, Dr. Abubaker.
Jazakallah khair, Dr. Nadir, for all what you do. And I'm meeting you for the first time, but I heard a lot about all the helps that you're offering to our candidates. Jazakallah kullu khair. Definitely, I mean, I want to start with one, like even those who started in really small programs, community programs. I mean, many of them with their work, with their hard work, publications, and like strong letters of recommendations. I mean, it just needs a little bit more of an effort, but you can end up in a really good program at the end if you're really a good candidate. While, I mean, if you started in a good program, a big program with big name, that just makes it a little bit easier for you. So it's more of, I mean, easier route versus not when it comes to the fellowships. Regarding the ranking, I just wanted to highlight a point that's, I mean, we've discussed it a lot with the program director and with many actually of the faculties as well. How the rank works is like with your preference, the applicant preference, not the program preference. So basically, let's assume you put, for example, DMC, then Beaumont as number 2, and let's say Hurley as number 3. I'm just speaking about Michigan here. If basically DMC ranked you in their top basically candidates, then you will match in DMC. If they did not, then you will match basically in Beaumont if they ranked you in the top like spots that they have. If not, then they will go to Hurley. So basically the way that the match works is in the preference of the applicant, not for the preference of the program. Okay. One more thing, I used to do it, and I mean, it's late, but maybe you recommend everyone, I mean, your juniors to do it, inshallah, in the future. After you finish the your interview, just, I mean, the comments that you'll put is what you remember, because especially if you have like 8, 10, 12 interviews, at the end, being very honest, you'll not remember which program was which. لأنه يعني most probably it's been like few months, if not like 4 or 5 months. You won't remember all what you've done and your impression at the time. So your impressions that you wrote about the program, whether it's friendly, people are welcoming, the program director seems supportive, their educational and didactics were excellent, like things like that will definitely have a value. And then put like your comments and give the grades for the program. Like, for example, I would give this program 8 in terms of education, a 9, for example, out of 10 in terms of like support for fellowship and research opportunities, 3 in terms of workload, 4 in terms of the city. And then at the end, that will make it much easier for you to rank. And I mean, until you certify basically your list, you can change that as well. So I mean, some would recommend you put your rank and then you can switch it before you certify. That works. Like I think putting like an Excel sheet with grading, try to grade the programs that you interviewed in. Speaking about the rank, and I think don't follow the herd basically in terms of, for the ranking, it's what works for you. What's your priority? For some, it's literally the fellowship. So put all your efforts into the fellowship if this is what you're looking for. For some, it's the support and the city. that should be number one for you. So just make sure that what are your priorities, highlight them, and rank accordingly. Not necessarily like, oh, I ranked this community program before that university program. Yes, because maybe that university program is toxic. I didn't feel comfortable. I felt not supported, basically. Even during the interview, my hunch wasn't great in that program. Okay. Maqdis, had the question.
Yes, I have a quick question. First of all, thank you everyone for doing all this informative presentation. Thank you as always, Dr. Nadir. My question is, if a program has a primary care route and at the same time a categorical route, when we rank them, do we rank them as a different program on a rank order list, like as we do on the preliminary and then categorical one, or do we just put the program categorical option there? I was confused.
If they
Thank you
have,
very much.
no, definitely. If they have two different numbers or names, like when you're ranking and you do the process of the ranking, it will show you as like DMC primary care route, or like whatever.
Yeah, it's like even on ERAS, when we apply, you get to apply it separately. Like you could just apply for on the rank order list.
So in the ERAS, it would be like ticks, if I remember right, at my time. You will tick primary and like regular track, right? It matters actually in the NRMP. When you're doing your rank, if the program is available as DMC only, or as DMC primary care track and DMC internal medicine track. If there are two different ones, those are two different programs.
Okay, so I will check that out. And thank you very much. So it doesn't matter whether it's different on ERAS, it matters
in the NRMP.
All right. Thank you very much.
Your rank. Yep.
Can I add something?
Yeah, sure.
Yeah, so in the NRMB website, when you go to the rank order list, for example, if you entered the subspecialty, for example, let's say internal medicine, and then you entered, for example, DMC, if that's the place you got the interview from, then you're going to have all the list of the different categories. Is it categorical? Is it prelim? Is it, the different things? So you can double check which one you do have with the NRMB code, because the NRMB code is different for everyone. So you can double check for the one that you have is the NRMB code, and then you can make sure that this is the one that you had the interview or you interviewed with.
And for many programs, the same interview will apply for all the positions, especially like for prelim and categorical. Many of them you can just, if you interviewed for the categorical, you can rank both of them, hoping if you didn't match in the categorical, maybe put the prelim in the bottom of your list. And then if things didn't go your way, you might end up in the like prelim route.
Thank you very much.
Yeah, you're welcome. I'm just checking the 7-minute video in your YouTube. Okay. Any question? Questions about ranking? Also, sometimes, I would recommend or advise everyone to speak to like those who like rank before you, especially if there is a program that you're not totally sure of whether it's a great program, how is their fellowship match, because many times actually the websites are not very informative. And during the interview, everyone will sell the program high and tell you that we have everything that you need. But if you have an insider that can give you like an insider view, I think that would help too. Okay. So if I interview that, okay, go ahead.
Sorry. We do have Dr. Duaa. She's raising her hand.
Okay.
Assalamu alaikum, Dr. Abubaker. Thank you so much for doing this. So my question is, do we, as a person who's not very experienced in visas, and as someone who's waiting for their TPS right now, I interviewed with programs that don't sponsor visa, but for now they're at the top of my list in consideration, but I'm still waiting for my TPS. And this will be like me risking it. And in types of visa, should we also consider the H1B versus J1 in our ranking, especially if, like, for example, I prefer a program with a J1 visa over the one who sponsors H1B visa?
It's a difficult question. Again, when it comes to the visa, when it comes to our situation in Sudan first, like TBS and the programs that do not sponsor visas, if you think that you'll get your TPS before you start your program, basically by the time that you're finishing your paperwork, that would help you a lot, because then they don't need to sponsor you with a visa, and that makes it easier for everyone. However, with TBS, the problem comes with renewal every year. This is just from my friends who went through the process. So if there is a limbo period in between where you don't have your TBS and work permit, then the program cannot, like literally, you cannot see patients in between. So that becomes really very tricky. The next question will be whether you go for a J1 and then get your TPS. Those can go like together, not necessarily one versus the other. The issue is that if you started with J1, TBS will allow you to work. However, because you started with J1, you cannot work outside of your program. So when it comes to moonlighting and like doing extra work, you cannot do it because your contract was signed as a J1. So that's another issue. Okay. J1 versus H1. And I'm not the expert actually when it comes to the visas, but this is what I've seen actually around me. If you can get H1, definitely it's better. It will give you an edge after you finish residency, because then you can go directly to get your green card and you don't need to do the waiver. But for H1, you have to have like a step 3, and the program has to sponsor you. Many of the programs will not sponsor H1 because it's an extra cost for them. It's like 10 or 12,000 extra that they have to pay for you. But in case that they sponsor the H1 is definitely preferred, and it will be better. J1 is easier to process, faster. I mean, needs less paperwork, but the problem will come when you finish residency. You have to either go back to your country for 2 years or do the J1 waiver, which is basically go for like an underserved area. And then you have to serve 2 years or 3 years until you get your green card, and then move on the process. One thing that I want everyone to keep in mind too, if you went with J1, many of the programs, actually, let's start with J1 first. If you're J1 and applying for a fellowship, most of the fellowships will accept J1 only. Very few programs will sponsor H1 as a fellowship or as like a fellow. If you had H1, and many of the applicants will have H1 and then apply for a fellowship, if this is your interest, you might end up with J1 again for the fellowship. So that's another trick. If you're going for a fellowship, H1 might not worth it that much. Again, it's better, but you might have to give it up and go back to J1 again when you're applying for the fellowship. I think this is as far as I know with TPS, J1 and H1. I hope that helps, but I am not the expert again. I don't know if Dr. Nadir has like more insight into that.
It does help. Thank you so much, Dr.
Yeah.
Thank you so much for the feedback, Dr. Abubaker. This clarify things. Hopefully it will help you guys.
Thank you, Dr. Abubaker. I think we have also two questions in the chat.
Okay.
One is about what's the importance of supplemental eras in the ranking list. And the other one is if I interviewed at a program, I can put both categorical and prelim if I'm not sure what I will be ranked in.
So starting with the first question, supplemental eras in ranking, like you mean the SOAP supplemental application for eras, or like I didn't get the question. Like Fatima.
Hello, everyone.
Hi.
I think Dr. Rufida mentioned it in her presentation, so I didn't understand. What did she mean?
The supplemental eras, to my understanding, is if God forbid you did not match, then they will give they'll give you the opening spots in all the specialties, and then you will apply in cycles. That's my understanding of the supplemental eras. Rufida, is that what was meant or something else?
Yeah, so there is another thing that's in the there is a primary rank list, and then there is a supplemental rank list. Let me share my screen. Okay.
I'm not very familiar with that then.
Yeah. Okay, let me share my screen. Okay, so for example, if you applied, like, this is the supplementary rank order list, and then this is the primary rank order list. The supplementary rank order list, as I mentioned, if you have applied for a program that's advanced, for example, in settings of, this is usually when it comes to neurology and other specialties that has a prelim of medicine, for example, transitional year of internal medicine. But I don't think, like, in the internal medicine, it's something that's very common. So, for example, certain programs such as Albert Einstein, there are advanced programs. So you need a year of a prelim before going to them. So you need to match into the two, like the prelim, and then also to match in the advanced in order to go to them from the second year of residency. So when you come to to creating your rank list, after putting the advanced one, then you will find here a supplementary option, and then when you press it, and then you're gonna add the programs and then search for the prelim of the internal medicine, and then after that you're gonna create a supplementary list, which is only contains the Albert Einstein, for example, the one with the prelim, if that's clear.
Yeah, so this is mainly for those who are applying, for example, for dermatology, where you're required to do a prelim year of medicine. So in order for the dermatology program basically to take you or to accept you in the match, you have to have also you have to secure a position in internal medicine, a BGY1 prelim medicine. So you match basically, but the match is from BGY2, if it makes sense, for example, dermatology. But you have to be able to secure a position also as a prelim medicine as BGY1. Then you will go for the BGY2. And this is what Rufida mentioned, is just the process of how you do that. I don't think lots of you need to be confused about it unless you're applying for like neurology, dermatology, anesthesia, or like plastic surgery, where you have to have like a prelim surgery in between. Otherwise, those who are applying for surgery, medicine directly, or pediatrics, you don't need to worry about this. So that was the first question. Is it clear, Fatima, now?
Yes, it's clear. Thank you so much. Thank you, Dr. Rufida and Dr. Abubaker.
You're welcome. Razan, so if I interviewed at a program, I can put both categorical and prelim if I'm not sure what I will be ranked in. Yeah, definitely. I mean, it doesn't hurt, even if they don't rank you in the prelim, for example. I mean, you're not paying extra for that, except if you're ranking more than 30 programs, then there is a fee, if I remember right, like from the old times. But most of us will not rank 30 programs. Okay. That's Razan. Raghda. or you can apply only for H1 program and fellowships, which are very small compared with J1. I mean, honestly, it doesn't worth it to apply only for H1 programs, because I mean, there might be specialties where there is no H1 at all. So, I mean, when you're applying for the fellowship, I mean, mostly you'll apply just broadly. Thank you, makes sense. Does radiology need prelim as well? Yes. It needs prelim. 20 this year, I think. Oh, you pay for, like, when you rank more than 20, you pay? Of course. They are generating more money. But it was 30 at my time, I remember. Thank you. I think those are all the questions, right? Okay.
Yes, those are all the questions in the chat. If there is another person who has a question, you guys can ask.
Okay, I think good luck. Is it advised to send letters of intent to the programs? Yes. Whether it counts or not, I don't know. But yes, show your interest, show this is what I liked, and make the letters personal. If you interviewed with the program director, for example, and you remember that you discussed about, for example, basketball or like anything that you discussed, or you spoke about basically the chances of you doing like community work or like a specific research or like medical education, for example, conferences, just mention that, like make it specific to something that you talked to me about in the interview. Okay. Don't use just the ChatGPT generic ones. Make it personal. I would like to suggest for those who applied or will apply soon to follow the Math social website. They post a lot of explanation and guidance material. Yeah. I mean, there are lots of forms and you'll find lots of information. The problem with that is not everything that's available online is verified. Some people just confuse you more, to be honest. So just be careful. Not everything that's written is correct necessarily. Does it make a difference in rank order links, ROL to rank the program if I have less than 10 interviews? I did not get the question. Does it make a difference in rank order list to rank the program if I have less than 10 interviews? I mean, that's Sarah. Can you speak? Can you just verify a little bit more of?
Assalamu alaikum. Thank you, Dr. Abubaker. I mean, and I can't explain it, but I mean, if you have more than 30 program, then the rank order will make difference. But if you have 10 programs or less, if you put the programs according to your preference, does it make difference? Like the program will, the order of the program, I can't explain it, but if you have less interviews, the rank order list, does it make difference?
It does. Even if you have 2 programs, it makes a difference. Like the first ones that you put is basically you're putting more chances into ranking in your first basically option, right? Or basically it's my preference to match in my number 1 rank. If it's not number 1, then number 2.
Okay. So if I have like 2 programs, I'm not sure about what I like both programs, and I don't know what to choose like the first order. So then
no, there has to be like there has to be a preference in whether you feel more comfortable in one the city is better, you're more supported in one versus the other. I mean, you have to get to the point where, I mean, you feel more, you know, this is more suitable, like to use than the other one. بعدين does it make it, if you're local, it doesn't make a difference, a big difference if you match in one versus the other, but definitely you have to make the decision of which one is better for you.
Okay, thank you.
Yeah, you're welcome.
Hello.
Yeah.
I do have a question. So if one of the programs I applied to, I did not signal, and at the beginning, the program director, she asked about the signal, like why I did not signal the program, because I am interested and I'm planning to rank that program as, you know, as my top choice. So do you think it's gonna make a difference? Although if I had a good impression from the interview, do you think it does make a difference? And like should I rank that program like as my top choice, or should I rank it later?
So if I'll start with the final part. If it's a program that you really like, I would rank it high.
Okay.
That's one. Two, the signaling thing is new to the programs themselves. So not everyone is very familiar actually with what to do with signaling and not signaling. Signaling made it really easy for the programs actually to give interviews, like when they started it. They might just filter the applicants based on like whoever signaled us, send them into, basically review their applications and then send them interviews. But many of the programs are still basically doing their classic way of reviewing the applications. When you said the program director asks you, why didn't you signal us? Depending on, was your answer basically convincing to her or him that you really like the program still or not? That's for you to answer. Second, you had another part of the question, right?
Yeah.
Signal.
So the program is actually like, it's the most one that I like, and I would like to rank it at the top choice. Actually, the program director did not ask me. One of the people recommended my name, but she asked that person that like why she did not signal us. But they ended up giving me an interview.
Did that person basically reassure her that you're really interested in the program? And I mean, you might speak actually to that person and they can still talk to her and tell her after the interview, she's really liking the program and she's putting it as number one. And I trust her basically that she wants the program.
I got you.
Yeah, okay. The signaling thing actually is new, and I mean, everyone is still figuring out. It's annoying, to be very honest, because it limits you to, it's mainly meant for the American grads, not for IMGs. But now that we're in the process, no one knows how to interpret it, and it's individual. I mean, it's program like specific. Each program, I think, has like a different way of doing it or using it. Okay. Any question in general? I think it's 3:30. Rufida, do you have another presentation coming or?
Yes. If there is any person who has a question, you can ask. If not, we really appreciate having you here. Thank you very much for answering all this question and for the support. It was really a pleasure having you here.
Okay, good luck everyone. And again, congratulations. You made it this far and inshallah, yeah, and wish you all the best. We thank you so much again, Dr. Nadir, for all you've done to and you do to the applicants.
Dr. Nadir, you're muted.
No, thank you so much, Dr. Abubaker, for your time and advice and tips and experience. Thank you so much for coming over and helping us. So I appreciate.
Islam. Thank you.
جزاك الله خير. السلام عليكم.
We have the coming presentation, we have Dr. Razan. She's going to be talking about the applications that are used by the interns or the PGY ones. If you're ready, you can present Dr. Razan.
Hello, everyone. So today we have a short presentation about the application that commonly used by the intern or the PGY one. Rufida, if you could share the screen.
Yes, let me share my screen. Can you see my screen now?
Yeah. So, Rufida, can you confirm that my voice is clear?
Yes.
Okay, so the first application that commonly used is UpToDate. It's a clinical decision support system where there is information about variety of medical topics. And like the name said, it's quietly updated regularly. So you get the least information. And there is a free trial, of course, for UpToDate, but if to get access to the full feature, you have to pay for the subscription. The second one is Medscape, which medical reference app that provide information about drug or diseases or procedure. Medscape has also calculator and drug interaction checker. The app is free for download and use. We have a Lexicom app, which is a comprehensive drug reference app that provides in-depth information on the uses and side effects and interaction and dosing. And also, there is a pill identification. Its benefit is to ensure drug safety and has a detailed drug information. You can use it to identify unknown pills and also to calculate accurate dosage. There is a subscribed, it's a subscription application, so you have to pay fees for the app. Also, we have the app for the new England Journal of Medicine, NEJM. It's well-known medical journal that established in the 1812 and constantly ranked among the most prestigious peer-reviewed publication in its field. With this application, you get to access high quality cutting-edge researches across various medical disciplines, stay current with the latest evidence-based practice and guidelines, learn from expert perspective and case studies published by the leading physicians and researchers. And you get to also explore interactive content and multimedia features for more engaging and learning. Accessibility, there is a free use for the basic access for some journal content and abstract and summaries, but to get the full content access, that requires subscription, either through the institution or by personal purchase. Also, there is a USF Hospitalist Handbook. So this is basically a concise and yet comprehensive bedside guide to the inpatient medicine. It's developed by the resident and attending physician at the University of California, San Francisco Medical Center. So it provides evidence-based and up-to-date. It provide concise summaries to the essential evidence-based information for the commonly encountered condition in internal medicine. It also easy accessible during round and consultation and patient care situation. It covers a wide range of topics in all of medical specialties, cardiology, critical care, and etc. It also includes algorithms, tables, and figures. So it does present information in a visually appealing and easy to understand format. It's actually free to access, so it's available for free mobile apps. Also, for taking notes, we have Evernote, which actually help in taking any kind of note, text, audios, videos, and image or web clipping. It's a great app for taking notes on lectures, round, patient presentation. Would also help to create a checklist, to-do list, and study guides. So it's basically help you to organize all your notes with tags and notes. It's free. There is a free and there is a paid version of the app. We also has a visual DX, visual diagnosis. It's a medical image diagnosis. It includes search. You can search for skin rash and other visual condition. It has a vast library of image and search filters. It requires subscription. You can search by any photo for a symptom, body region, or diagnosis. It gives you a differential diagnosis and give you a list of the potential differential diagnosis, and also help you with the detailed clinical information to learn about the diagnosis, the causes, the symptoms, and the treatment. And definitely, there is multiple medical calculator apps like MedCal, the one that Dr. Nader used earlier for the Wills criteria. We have also Medscape QX calculator, and it helps in medical calculation for the common medical calculations like the BMI, creatinine clearance, and medication dosage. So there is many free and paid options. We also have American Heart Association AHA guidelines. It actually for the CPR guidelines and training. So it gives you the latest CPR guidelines and training resources, prepare you for emergencies, and improve patient care. It's a free app. We also have Doximity that Rufida used earlier. It's a secure communication platform. You get to message with healthcare professionals and collaborate and information sharing. So it is also a free and a paid version available. So the last one, it's actually for the internal medicine resident, is called MCASP. It has a question bank for the internal medicine to help. It was developed by the American College of Physicians, ACP, and it focused on giving question bank and self-assessment, so to reinforce the knowledge and also help in preparation for the various exams and training exams and also board exams. So it has a complete learning system. It has a question bank, and it has several study tools like flashcard and practice exam, and you can organize a personalized learning plans. And also you can have a CME or MOC credit. You earn credit through while you learn in the app. And that's a bit about the app. So if anyone has a question or a comment or has another app.
Thank you, Dr. Razan, for your presentation. Also, I just have one point to add, is that Doximity is also something that I found, like for those who are planning to apply next year, Doximity is something that I found very helpful during preparing for the interviews, because, like before the interviews, we try to, search about the people that they're gonna interview with us, their research area of interest, their, specialties. So Doximity is one of the websites where we can find a lot of information about the background of the people we interview us in a certain programs, beside the other usage. So if anyone has a question or a comment before we go to our next presentation, if Dr. Nadir also has an input.
Thank you so much, Dr. Razan, for this great presentation, sharing the tips. Yeah, I think it's useful if you are planning to use Doximity in the future, but all of these are very useful tools. Thank you.
Thank you, Dr. Nadir.
So our next presenter is Dr. Rawan. If you're ready, you can share your screen. She's going to be talking about the usage of Google Scholar for academic research.
Hello?
Yes, we can hear you, but your voice is kind of far.
Can you hear me?
Yes.
Before, I'll reintroduce Rufida, and I will be talking to you about the use of Google Scholar in academic search. First of all, we need to appreciate that Google Scholar is not just a search. It has some features that allow you to perform a targeted and a focused search on your topic, and also to organize whatever finding and resources you find within it. Okay? Let's take a look on the home page of Google Scholar. This is the home page. This is the searching bar over here. This is your profile. This is a drop-down menu in which you have another feature. This is my profile and my library, which are shortcuts. As we will see it again. This is the menu. Has having my profile, my library, alerts, and metrics, and the most importantly, advanced search. These are different functions available on Google Search. They will help you to explore new researches, perform targeted search, and track and organize your sources. Understanding how this works, this is what we're going to explain. Okay. My profile, Google Scholar profile, is defined to help authors showcase their academic publication. It allows authors to check who's citing their articles, grab citation over time, and compute several citation metrics. Published authors can also make their profile public so that they appear in Google Scholar results when people search their name. In short, a profile, you can create a Google Scholar profile. And if you have, of course, if you have a published papers, you can follow who's citing your paper, and you can make your profile public whenever a person come and search your name, your profile, your Google Scholar profile going to pop out for them. This is simply how you're gonna make your profile. You're just gonna type a basic personal information, and there we go. Now we have a profile. My library section is where your personal house it's your personal warehouse where you can save, organize, and categorize your sources. My library offers the ability to search for specific articles using the search bar. You have the option to sort your saved articles by date. My library. This is some articles that have been saved to the library. Here in this search section, you can search certain articles that you previously saved to the library. This is how your library sorted by date. You can choose from older dates to new dates as you. This is a PDF form of the articles you've already saved. Okay. There is a label feature, as you can see here. My label, managing label. There is a label feature allow you to create specific tabs that are similar to Drive folder, where you can organize articles based on topic, read status, and more.
Rawan, your voice has disappeared. Can you hear us?
Yes, I can hear you. You hear me now?
Yes.
What was the last thing? Do you hear me now?
Yes, we can hear you.
Let's assume that they're working on two different topics. They are working on topic cited in the impact of occupational hazards, for example. Yes. We have another topic we're working on regarding risk of cardiovascular disease. And what we're searching about data for both topics at the same time. This is what the labeling is for. We press on create new labels. Then let's say for example, cardiovascular. And let's create another one for traffic. For short. Okay. And now we have two different labels and two different categories. For example, let's suppose okay, let's search for
We can't hear you.
Can't hear me?
Yes, but your voice is very far.
Is this any better?
Yes, now it's better.
Okay, let's, for example, look for the risk of cardiovascular. And now we can say save, and here we see that our labeling, save to our labeling, and done. When we go back to our library, we will find that our article has been saved to our library with the labeling of, or the foldering of the label on regarding as we said, this is the process of creating labeling that we already went. Alerts simply is a notification. Alerts allow you to build search that return results to you passively on autopilot. You can indicate your alert based on various criteria such as keywords, non-item, specific author, and so on. Simply alert is like an notification. You simply telling Google Scholar that you want set a notification about an article, new article, trending on a certain keyword that you specify, and you want to receive those alerts on the Gmail. How you create it? You write the keywords of the certain thing that you want to get the notification for. Then Google Scholar going to send it to you. Let's go to other part. Scholar method helps you make one but that means for the most trending article.
Rawan, your voice is still kind of muffled. Can you hear us, Rawan?
Is it better now?
Yes, now it's better.
Okay. As we were saying, metrics is the next function that Google Scholar can perform. It's simply telling you about the most trending articles and the most the most trending articles in the most trending journals. This will help people to appreciate important topics in their field.
I think Dr. Rawan has some technical issues.
No worries. So I'm gonna just share with you a little bit of the Google Scholar. So what you need to do is you need to have basically an account with Google. So you log in and you will have your profile, and then you have your library. In addition, you can create some alerts. Along with that, you can add some labels. So these are the features. So basically, it's a way of collecting your articles or references when you are trying to write an abstract or you want to write a paper or manuscript. So when you have something that you found you think it's useful, you can add it here. And if you have a lot of papers, then you can organize that by using the labels. So the label feature, you can create new label here and then match that article to the label so that, for example, I'm interested in dementia. So I'm gonna just write dementia, and then this article will have the label here. If there is another one, I can label this as well with the dementia. So I'm gonna just click on that and it's gonna have, so these are the two labeled articles. So instead of searching all the list, I have 20 something, I can just search by labels. Where is my label? My label is dementia. I'm gonna check it and it will sort out only the, it's gonna list the list that I wanted for that label. And as far as alert, so you can create some alerts also the same way. You create new one if you have I'm interested in intelligence, artificial intelligence, for example, I can create that. Or for example, also dementia, I can just add that, and then I can include the relevant results, or I can keep it empty, and this will be my alert. So each time there is an article that meet that alert, it will show up in your library, so you can read it. If you don't want it, you can delete it. Just click here and it will be deleted. So it's a useful tool that some of you might find useful. So we just want you to know how to use it, and you can try it and play with it and see if it helps you. That's well and good. If not, there are other different tools that you can also try. Thank you. Thank you, Dr. Rawan, if you can hear us. I think you have some technical issue with the mic, but we get the idea. Thank you.
Thank you, Dr. Nadir and Dr. Rawan. So our last speaker for today is Dr. Wael. To share his experience. He's one of the seniors. He's going to be sharing his experience. If you're here, Dr. Wael, the floor is yours.
Actually, I don't see him. He did not join. Maybe he had some situation there, but I was trying to ask some of the fellows in the past to share their experiences and let you know the other options besides going to the residency, just in case some match to fellowship and join the residency. So always try to see how you can secure a position going forward. And if it's difficult this time, maybe until you apply next time, you will do something else in the meantime. So one of the options will be doing either research fellowship, like some of you did in Florida, I think, and some did actual clinical fellowship, like in geriatric or nephrology. So Weil is one of the ones secured internal medicine after he went and did geriatric fellowship. So I wanted to let him share with you his experience, but unfortunately he's not available now. So we can move on to the next last agenda updates. Thank you. Go ahead, Rufida.
All right. Thank you, Dr. Nadir. So if anyone has any update or any with regard to the research or applications, you can unmute yourself. I can start. There is Dr. Ala. She's not here, but she told me to update you that her paper got accepted to the American Academy of Neurology. So me and her, we're going to be going to this year meeting.
Excellent. Congratulations. This is great news. Good luck.
Thank you, Dr. Nadir. Thank you very much.
Assalamu alaikum, Dr. Nadia. How are you?
Walaikum
I,
salam. Go ahead.
I have a quick question regarding our paper. So 2 months ago, we submitted a paper, and recently I've submitted an abstract to join a conference, and it was accepted. My question is, how would I know if, because I was reading that there's a lot of frauds and what they call a predatory conferences. So how would I know if this conference is legit and it's a good opportunity to participate on?
Excellent. Do you want to go ahead, Rufida, and answer, and I will follow up?
Yes. So there are, like, you can go to just simply in Google, like you can look it up. If it's valid, you're gonna find like previous publications, previous people who went to this conference, and also certain conferences they keep like their posters from previous year. There is an application, but I don't remember its name, that it can shows you the conferences, like the upcoming conferences in the certain region that's you're interested in. So that's also can be a really helpful tool.
Yeah, sometimes you may have the email or the invitation to publish in their journal or attend and publish in the conference. And if you look closely to this invitation or email, you can either look at the coming from, so the email might be not valid email, like Google email from a university. So it doesn't match. You're supposed to have a university email coming to you as an invitation. Or if it's a company or organization, this email is supposed to come from the company email or organization email. But if it's from Gmail or from other free emails, then this will raise a red flag. Number two, some of them might have mistakes, like the spelling mistakes, or some they just because they want to mass send all these emails to all, like they found your list 50 physicians, they send it to 50 or 500. So they don't care about the actual content specifically. They don't review what they send you. So if you look and find there are some error mistakes, this also red flag. The third way is to look at the other speakers. Sometimes they will list, we have this number of speakers will be on the conference, and they will list them. So you go to their websites and see if they have participated in the past in this conference or not, or if they published according to the topics that they are listed on or not. Then if they are also, if there are some mismatch, then you will see that it's not valid. Some of them might be overseas, from China, from Japan. I have got some of these. So if you are not interested in going there, so don't bother. So there are certain ways of finding out. Sometimes the website itself, if they ask you to go to the website, you go and verify if they have a conference last year, who was there in that last year, and was that published in PubMed or other journals. If it is, then it's a valid one. If it's not, then you think it might not be a good idea to communicate with them. So don't waste your time.
All right, thank you a lot, Dr. Nadia.
You're welcome. Good question. Any other questions or updates?
Good afternoon.
Go ahead.
Dr. Nadia.
Go ahead, Nafisa. Go.
So I have a question that is some fellow reached out to me regarding they finished already the 1 year the fellowship with us, and they would like to have a certificate.
So they can send me an email and I will forward their certificate.
All right. Okay. Thank you so much.
No problem.
Hello.
Hello, go ahead.
Hello, yes.
Dr.
Hello,
Hannah.
everyone. I'm Dr. Hannah. I'm new joining to the fellowship.
Sure.
It's nice to meet you and to give me this opportunity for a new addition. It will be addition for me and for all of you us. I'm asking because I'm not. You didn't add me to any group, so I just registered my application.
Yeah. So you first of all, welcome to the program, and we are glad to have you. And also, we have more new fellows. So welcome to those
Thank
who
you so
joined
much.
recently. So we'll be in touch. We'll send you an email, and if you join a group, that will be great. If you have not yet, maybe we will create a new team for you, the newcomers. So and then we will identify someone to be the leader in that team. So we'll be in touch.
Hello, hello everyone. Thank you, Dr. Nader. I'm Faiza. I'm also a new applicant for this research fellowship program. So I'm so glad I have found this group, and I'm getting to hear all this information, very useful for me. So I'm also awaiting an email, but I contacted a few team leaders and they were grateful to join me in groups. So right now I'm in Dr. Naoud's gold team. So I don't know if I should wait for another email or should I just continue with this team?
So if you join a group or a team, that's well and good, and you can talk and continue with that group. There is no problem with that. I'm just lagging behind with organizing all these new fellows. So I want to have a good number of fellows so that I can create a new team, or if there are just a few of them, then we can add them to the existing teams that are there. So usually I send email stating that the team leader will be reaching out to you. So we will update you in the coming days as far as joining the team. If you already know a team leader, you can approach that team leader and can join the team. And sometimes in the past, people join a team that they have friends or someone they know so that they can work together. It's just an organization for us so that you will have some seniors in the team if you have questions. If you want to present or join or do other activities, the team leader will organize and answer the question or lead you to the right direction. It will help me a lot instead of all new fellows will ask me the same questions, then the leaders might have better answers. Thank you so much and welcome all of you. Dr. Naim, go ahead.
Hello, Dr. Nader. Hi, how are you? And thank you for the letter recommendation. I received it through the email. I would like to appreciate and thank you. Thank you so much for that letter.
You're welcome, no problem. And I wish you all the best.
Thank you.
Again, I'd like to thank you, Dr. Rufida and your team for great presentations today. Thank you everyone for joining and thank you for the update. And I wish you all the best and hopefully we'll hear good news in the coming few weeks for those who will apply and send their ranking list. So thank you so much. Go ahead, Dr. Rufida, if you wanna.
Thank you, Dr. Nader, for your input and constant support. Thank you all the presenters today, and thank you everyone for listening today.
Thank you. Have a wonderful day, and I'd like to thank all who attended today and those who will look at the recording and watch the recording later. Have a wonderful day. Assalamu alaikum.
Alaikum assalam. Thank you so much, Dr. Nader.
Alaikum assalam.
Shukran, Dr. Nader. Thank you, everyone.
Thank you, everyone.
Thank you, Dr. Nader.
Thank you.
السلام عليكم ورحمة الله.
في أمان الله.